Good morning or good afternoon, everyone. Today, I'll be presenting this topic, pharmacotherapeutics of the common postoperative pain medications in the Orthopedic Institute of Advent Health Orlando and its impact on rehabilitation. The objectives of this presentation is to describe the anatomy and physiology of pain, identify the common pain medications provided to post-surgical patients in the Orthopedic Institute, understand the pharmacotherapeutics of pain medications, discuss the proper timing of therapy to optimize care and rehab concerns associated with pain medications. And last would be to provide a handout of the summary of pain meds as a guide for therapists. So to understand this pain medication, we have to also understand the anatomy and physiology of pain. So I'll be discussing the ascending and descending pathways of pain and also the peripheral and central sensitization of pain. So pain is a complex sensory and emotional experience associated with actual and potential tissue damage, or described in terms of such damage. In contrast, nociception is the neural process of encoding those noxious stimuli. There are multiple ascending and descending pathways that enables modulation of nociceptive input and each synapse from periphery to corticothalamic networks. So in this diagram, So as you can see in this diagram, there are ascending and descending pathways. The ascending, as you can see in this laser pointer, goes up over here to the spinal cord and up to the brain. And then there's descending pathways that goes down and goes back to the spinal cord and back to the peripheral area. So the ascending pathway during the acute pain or acute injury, a well-localized first pain sensation is transduced and transmitted by the A delta nociceptors right here on the periphery, followed by a dull and more diffuse second pain sensation by C fiber. So that through transduction, it travels up to the dorsal root ganglion and then to the dorsal horn of the spinal cord. The encoded electrophysiological neural signal travels to the dorsal horn of the spinal cord, and then the signal is then transmitted across to the second order neuron to the opposite side of the spinal cord before traveling upwards to the thalamus in the brain. The ascending tracks synapses to the third neuron in the thalamus and midbrain, or brainstem particularly. From the thalamus, the fibers project to the cerebral cortex up here, which includes the somatosensory cortex for the perception of pain. And then the descending modulation or the descending pathway mainly does the modulation of pain or affects the how the pain is perceived. The descending inhibitory signal of the cortical from here and the thalamic origin, that's right here, is relayed by the rostral ventromedial medulla and the periaqueductal gray area of the midbrain over here. These are the primary sites of action following systemic administration of opioids and cannabinoids. These are the different kinds of pain medications. The efferent signal is transmitted through the spinal cord, through here, and to the dorsal horn. At the dorsal horn, the descending supraspinal inhibition results in the activation of the opioid receptors and the alpha-2 adrenergic receptors to inhibit the C fibers over here and the A delta nociceptors. Now, what happens to the now you could ask, why do we still pain? Why do we still feel pain after the initial injury? So, and that's because of the peripheral and the central sensitization of pain. So we will discuss that here. Following the tissue injury, there's a cascade of events involving primary sensory afferents and sympathetic efferents. White blood cells, such as the neutrophils, mast cells, macrophages, and platelets includes and the white blood cells induces peripheral sensitization. The activation of the peripheral nociceptors on the skin in response to stimuli such as heat, injury, mechanical pressure initiates the release of chemical mediators at the site of injury. Mast cells, macrophages, neutrophils release several pro-inflammatory substances, which are right here in this box. Okay, there is an increase in the efficacy of transducing ion channels, a reduction in the firing threshold of voltage-gated channels, and exaggerated response following activation of the channels over here. These voltage-gated sodium channels, which is located right here, and the capsaicin receptor are intimately involved in the activation and sensitization of peripheral nociceptors. Nerve growth factor is increased in inflammatory states and induces hyperalgesia. So that's why after initial injury in the acute phase, we could still feel the pain after the initial injury. And then how come we still feel it after the acute phase? What happens to the subacute and the chronic phase? How do we feel pain there? That is explained by central sensitization. The term central sensitization is used to describe the phenomenon of wind-up or long-term potentiation of secondary hyperalgesia. Persistent pain inflammation causes activation and repetitive firing of the afferent C fiber over here, which triggers the release of excitatory neurotransmitter glutamate in the synapse of the dorsal horn. And this is accompanied by the release of substance P right here, BDNF, and neurokinins, which causes persistent depolarization of cell membrane. Additionally, activation of AMPA and NMDA receptors by glutamate stimulates the microglia and subsequent induces the release of cyclooxygenase enzymes 1 and 2, which is found right here, nitric oxide and pro-inflammatory mediators. Long-term potentiation and at individual synapses are thought to be important in the learning and memory, may also be the mechanism of hyperalgesia and central sensitization. So that's why we still feel pain even weeks after the initial injury. Now, pharmacology of pain, uh, the pain medication, as it works, as the transmission of pain involves many different receptors within the peripheral and central nervous system. Multimodal analgesia is best employed to optimize pain control and limit side effects. Optimal analgesic drug therapy can be utilized to selectively target areas that include nociceptor transduction, transmission, and central perception and modulation of pain. So in those different areas in the transmission of pain, pharmacology could be utilized to effectively modulate pain. And so we're going to be discussing the different pain medications that we use in the Orthopedic Institute. So we classify it by drug class, use, and the mechanism of its action, and then adverse reaction. The first drug class that we're going to be talking about is the aniline analgesics. The generic is acetaminophen. Brand names used in the Orthopedic Institute are Ofirmev and Tylenol. This drug class is used for acute and chronic pain. It's best for mild to moderate pain, and it's also used for antipyresis. So how does this drug works? In two ways. Although not fully elucidated or explained, the analgesic effects are believed to be due to the activation of descending serotogenic inhibitory pathway of the CNS. Interactions with other nociceptive systems may be also involved. The antipyresis is produced from inhibition of the thalamic heat-regulating center, so it's from the central nervous system. Adverse reaction are acute hypotoxicity, skin erythema, blister, and rash. The next drug class that we're going to be talking about is the COX-2 inhibitor or the cyclooxygenase 2 inhibitor. It is a type of NSAID or non-steroidal anti-inflammatory drug that inhibits prostaglandin synthesis by decreasing the activity of the enzyme. So remember, in the central sensitization, the COX-2 substance is actually produced by the glial cells. So this medication interrupts that. The generic name of this drug class is celecoxib, and the brand name that we usually use is Celebrex. It is used, as I said, for anti-inflammation, particularly for ankylosing spondylitis, rheumatoid arthritis, osteoarthritis, juvenile idiopathic arthritis, acute flares of gout, treatment of primary dysmenorrhea, and acute migraine. It is effective because it inhibits the prostaglandin synthesis by decreasing the activity of the enzyme COX-2, the COX-2 substance. Adverse reactions are hepatic and renal dysfunction, fluid retention, hypersensitivity reaction, cardiovascular events, which is arrhythmia or tachycardia, and GI upset and irritation. The next drug class is opiates or opioids. Opiates is a type of analgesic agent derived from opium poppy. It's a kind of plant. Generic drugs are hydromorphone, hydrocodone, morphine, and oxycodone. Brand names that we use are Dilaudid Lortab, MS-Contin, OxyContin, and Percocet. It is used for the management of severe pain. Remember, it's for severe pain. Hydromorphone is particularly used for the management of pain and sedation of critically ill patients. For the mechanism of action, these drugs bind to opioid receptors in the CNS. So from the central nervous system, it causes inhibition of the ascending pain pathways. It also alters the perception and response to pain and produces generalized CNS depression. As you can see, opioids could affect in all the areas of the transmission of pain through the transduction, modulation, and perception of pain. And then the adverse reactions for opiates are vomiting, nausea, constipation, sedation and pruritus, dry mouth, mental confusion, urinary retention, and respiratory depression. Then local anesthetics. This is what we use in the on-cue pumps. So the generic name is bupivacaine, sorry, and the brand name that we use is Exparel. Local anesthetic blocks both the initiation and conduction of nerve impulses by decreasing the neuronal membrane's permeability to sodium ions, which results in the inhibition of depolarization with resultant blockade of conduction. So from the periphery, it already stops pain. And it, as I said earlier, it is used in the on-cue pumps to slowly administer local anesthetics to and around the surgical wound areas or near to the peripheral nerves for post-operative analgesia. It is usually used in knee replacements. And as we know, the nerve that they usually numb the area is the saphenous nerve or the femoral cutaneous nerve. And adverse reactions to this medication is chest pain or pressure, ringing of the ears, muscle twitching, tremors, difficulty in breathing, stomach upset, anxiety, restlessness, confusion, and drowsiness. Next will be the skeletal muscle relaxant. Although this is not a pain medication, this is an adjunct treatment for pain. It is utilized for acute pain due to the muscle contraction and spasm resulting to immobilization. It does not affect on neuronal conduction, as I said, neuromuscular transmission and muscle excitability. The generic name is methocarbamol. The brand name that we use here is the Robaxin. It is used, as I said, as an adjunct treatment for treatment of pain through the relaxation of muscle spasms. Adverse reactions are cardiovascular events, drowsiness, skin rash, nausea and vomiting, ataxia, and insomnia. And our last drug class that we have that we utilize here in Orthopedic Institute is the anticonvulsant, uh, best known for the brand name Neurontin, and the generic is gabapentin. Anticonvulsants, particularly gabapentin, is a novel drug or is a new drug used to the treatment of postoperative pain with anti-hyperalgesia properties. For the orthopedic surgeries, there's a study of a double-blind randomized control trial by Kani et al. Showed that the efficacy of preemptive use of gabapentin on reduction of post-operative pain in the first 24 hours after lower extremity surgery. Its primary use is for control of seizures and to relieve pain from shingles in adults and other nerve pain. So going back to the study, they found out that if you use gabapentin or Neurontin before the surgery, it actually reduces pain afterwards in the first 24 hours. The adverse reactions are drowsiness, fatigue, ataxia, peripheral edema, depression, altered mental status, generalized weakness, and xerostomia. Now, what do we have to be watchful for? So rehabilitation timing, we're going to be discussing the dosing, the timing, and rehabilitation concerns. For aniline analgesics, there are two brand names that we use, Ofirmev and Tylenol. The dosing for Ofirmev, we have it's through IV, it's as needed, and the peak time is 15 minutes. So after the IV, provision, we should be able to see the patient within 15 minutes. So it's fast. Tylenol is by oral, um, and it's every 6 hours, and the peak time is from 10 to 60 minutes. So we could see the patient within an hour. There's no negative impact on rehabilitation because this medication has no it doesn't result to any orthostatic hypotension or any adverse reaction that would impede mobilization. It allows the benefit of pain relief for many physical rehabilitation patients without the loss of attentiveness and concentration. For COX-2 inhibitors, particularly Celebrex that we use here, we use it orally twice a day. The peak time is from 0.7 to 1 hour. So within an hour, we could schedule the patient to be seen for therapy. The risk, the rehab concern are due to the high risk of cardiovascular events such as heart attack and stroke. Therapists should be cautious and closely monitoring their patients while providing exercises that is above the aerobic threshold. So when you're doing more of, in particularly in our rehab, we're walking the patient the whole way. If you notice that the aerobic threshold is being met, like the heart rate is going to 110 or I would say about 120 to 130, you should be watchful for the signs and symptoms for cardiovascular. The therapist should be attentive to the patient's cardiovascular, as I said, during activities, and also educate the patients to stop if there's any symptoms that are noted. All right. For our opioids or opiates, we have 5 particularly: Dilaudid, Lortab, MS-Contin, OxyContin, and Percocet. The dosing are different. We have Dilaudid, which is through IV. It's used for breakthrough. It is immediate. 10 to 20 minutes, we could see the patient. Lortab, which is a combination of hydrocodone and acetaminophen. It is per RM or by mouth or oral. We could see the patient within an hour. So you could see the pattern right here. If you have medications that are given orally, we could see the patient within an hour. MS-Contin is through IV, and it's 20 minutes, the peak time. OxyContin is orally and is every 4 hours. It is utilized for mild to moderate pain. And we could see the patient within half an hour to an hour. And lastly, Percocet, which is a combination of oxycodone and acetaminophen. It is also orally given, and the peak time is half an hour to 1 hour. So for rehab concerns, sedation and GI discomfort are very common side effects of these opioid analgesics, so which can negatively impact our physical rehabilitation. Precaution is needed when out of bed and ambulatory activities are performed to avoid falls. Respiratory depression is also common, which requires oxygen supplementation when oxygen saturation is low. So monitoring of oxygen saturation through pulse ox and intermittent deep breathing may be necessary during therapy to ensure adequate oxygen is maintained during therapy. It is because of the decreased, breathing of the patient. That's one of the side effects. Local anesthetics. So it is found in our Q pumps, particularly Exparel, and it is delivered through subfacial, and the peak time is is within 30 to 45 minutes after it is activated. Our rehab concern would be for local anesthetic. Um, it allows for early mobility for patients after surgery. So that's the advantage of this compared to traditional analgesic methods. This is through the study of Nassar, Fahy, and Michel in 2020. The therapist should assess the muscle strength of muscles approximate to the infiltration site prior to out-of-bed and ambulatory activities to ensure muscle failure is prevented during such activity. So we should assess the muscle strength of the patient first. The therapist should also use the visual analog scale to assess the patient's pain and be attentive if significant increase in pain is noted. Why? It's because it could be a sign that the on-cue pumps are not working or not delivering adequate anesthetic. The medical staff should be notified to assess if there is delivery problem that requires adjustment of the pump. Therapists should be observant of excessive sedation and respiratory depression, both which is a sign of overdosing anesthetics. This happens sometimes when the on-cue pump infiltrates the intravascular. So it becomes systemic and could also result in sedation. So the monitoring of oxygen saturation through pulse ox and intermittent breathing is also necessary for these patients to ensure adequate oxygen during therapy. Skeletal muscle relaxants. So sedation, the particular brand that we use is Robaxin. It is delivered, orally and every 8 hours. The peak time is 1 to 2 hours. Rehab concerns would be sedation and generalized weakness. And we should be looking for these particular symptoms. Precaution is needed when out of bed and ambulatory activities are performed to avoid falls. The use of assistive device is highly recommended to address ataxia during these activities. Therapists should also be cautious and closely monitoring patients while providing exercises that is above the aerobic threshold because of the cardiovascular events. Therapists should be attentive to the cardiovascular symptoms and educate the patient to stop if any symptoms are noted. And the last drug class that we're going to be talking about is the anticonvulsant, particularly the Neurontin. The dosing is through orally and every 8 hours. In our dosing, we have particularly a timeline, which is for 30 days. And the peak time for this medication is 2 to 4 hours. Rehab concerns are headache, dizziness, sedation, gastric disturbances, such as nausea and vomiting, which could be a barrier for effective therapy. Therapists can address this by scheduling therapy when symptoms are relatively mild. There are also cerebellar side effects such as ataxia and are also common and should be addressed during therapy with coordination exercises to resolve this concern. Precaution is needed when out of bed and ambulatory activities are performed to avoid falls. Of course, we have to use assisted device appropriately so that we could avoid falls. So the end product of this in-service is the handout. And I'm gonna make this available to our teams in the file section. So you could read through this. These are the most common pain medication that we utilize here. Um, on the first column, you could see the brand names. Second column would be the drug class. Next, dosage, peak time, adverse reaction, and then the rehab concerns. The purpose of this handout is to provide the therapist a tool to reference some of the most common pain medication provided post-operatively in the Orthopedic Institute. To use this handout, the therapist matches the brand name of the medication being inquired and its dosage, and compared to the medication administration record, or the MAR, in the power chart or the Cerner that we have. This handout can provide quick reference for peak time and proper timing of therapy, adverse reaction to look out for, and rehab concerns in order to conduct safe therapy. References are here. Do you have any questions with regards to the common pain meds that we discussed? Sorry, I probably talked too fast. I have a lot of slides to discuss. By the way, there's a post-in-survey survey. If you would mind to fill this out, I appreciate your feedback. Right here in the chat, I put it there. That will be very helpful. All right. Got 3 more minutes. Any up? Nay, you have a question? You could unmute yourself if you use your mic, or you could type it in. Areas and department should focus on the base of what in your opinion are some areas we as a department should focus on base of this information. Okay. All right. Yes, as a department should focus on base of this information. So as a department, we should focus basically to the adverse reaction and the rehab concerns. So on the handout that I made, I particularly in the last 2 columns, I put the details there and what to look out for and what should we be doing as a rehab personnel, like rehab staff, like reporting the symptoms, taking note of this and notifying the nurses and the doctors about the adverse reaction, because maybe the medications are, they're patients getting overdose dosages or overdosing of this medication, or they are not receiving enough medications. Also, if the patient has allergic reaction to the medication. So those are the things that are particularly useful to look for, so that we could maintain patient safety through our therapy. And of course, in general, when you're dealing with patients with pain medication, I usually look for the vital signs, making sure that they're stable before you get the patient out of bed, and then test the muscle strength, coordination also, so that before you ambulate the patient or do gait training, you are quite confident that the patient will not fall. So preparation is the key here. Yeah. Good question, eh? Thank you. Anything else? All right. So if you don't have any other questions, thank you so much for attending this in service, and hope you learned something from me. Have a good one, and thank you.